structure
Okay,
as
so
like our
I have
reference.
depth.
Okay, so
90
gracilis is our
degrees
reference structure.
is just resting against my body. Okay?
So passively
So,
resting the knee
from this
against
position, if we take
the
our hand
body
and
of
we
the
just lay
clinician.
it on the medial thigh and just sort of perpendicularly palpate, you should
Okay, reference
fairly
structure of
easily be able
magnet,
to feel that adductor longus.
adductor
Okay? Again, if you
longus,
can't
magnus.
keep this position, now this hand can add a little bit of resistance. Go ahead and pull inward. And you should then very easily be able to feel it. Okay? Such that if I mark that adductor longus, here is the back side, here is the front side. Okay, so this is kind of the anatomy that I was trying to tell you about. If you look strictly from this view, it only looks like the adductor is this wide. Okay? But as we saw, when you then switch and understand that the femur is all the way over here, there's some width to this adductor compartment that we have to consider.
Okay, so there's good width to the adductor
So that's
compartment.
the first thing. The second thing is as I said, there's lots of
Here's the
loose
femur.
skin in that adductor compartment. So when we palpate, and specifically then get so coming distally,
Okay, so then
and
getting
then
the
do your
skin
palpation.
tension out of the
Okay,
way,
well,
or
you
slack
pull
out of the
that
way,
skin up.
with the
Now,
left
if
hand
I
here.
let that skin go, it's all down
And then
here. I'm never
palpating again
pulling on it
perpendicular
if I pull it
to
off right from
the
beginning. You guys
adductor
understand what I mean?
tendons
So you either have
with the
to
pads
be
of the
comfortable
other
just kind of
hand.
pressing down onto the skin and not wriggling it or pulling it in any direction because it's really uncomfortable, or get in the habit of just pulling that skin down away from that area and then doing your palpation from there. Okay? So, first things first, adductor longus. Pull the skin. Now I want to get to that anterior face, so I'm going to perpendicularly palpate, and now I'm going to roll into that anterior face. So you can see how I can roll in and then compress down onto that anterior face of adductor longus.
Okay, so onto the anterior face of adductor longus, just medial, still in the femoral triangle as denoted by the marker.
Okay, so now I'm perpendicularly palpating the anterior face of adductor longus. I'm going to walk my way down.
Okay, so skin slack taken up.
You're probably going to be surprised how distal you can feel the longus. Okay, I still feel it all the way to here. Okay? Now, as I said, if we haven't considered the skin, and you're not deep enough, you're just going to be moving skin. If you haven't considered skin and you pull that skin with you as you go, now you're creating a lot of skin tension, which is really uncomfortable. Okay? So that's why we get in the habit of either just pulling it out or compressing right onto it as you palpate. Okay? For the posterior face, if I come back here,
so posterior
and I
face
go off the back side,
adductor
so here's the
longus.
width from the side view, but now I can come off the back side and look, I'm going to go in and push back up, and now I can perpendicularly palpate in this fashion that posterior face of adductor longus. Walk my way down.
You can see the adductor magnus tendon there, and then coming into the posterior face tendon, wrapping around.
Okay, so I have both sides of the adductor longus, anterior face and posterior face. So,
okay, so
now that
anterior
we understand
face
that
right
there's
to
two
here,
faces, we have to
and then
understand
walk.
how each face has its own
Up
assessments.
and under to get the posterior
Remember,
face.
the direction is going like this. So if I'm on the